Temporary removable partial dentures. The purpose of this lecture is to discuss the use of partial dentures as interim, transitional, treatment, and definitive temporary partial dentures. These categorize the temporary RPD according to usage. Removable partial dentures designed to span limited intervals of time are used frequently in the treatment of prosthodontic patients. This topic is discussed under 4 headings, primarily as a convenience, according to how they are employed. The indication for these temporary RPD will be discussed. Following that, we will discuss fabrication of the prosthesis. Some common terms for these types of partial dentures are flipper, plastic partial and partial plate. Although the use of these terms is not to be encouraged, frequently the patient will understand if layman terms are employed. These temporary partials may be constructed from a variety of materials, but most are of acrylic resin construction. Occasionally it may be possible to use prefabricated metal parts as well as parts from the patient's previous RPD. The patient's current RPD may assume the nature of a temporary restoration under a variety of circumstances. A list of uses for these prostheses is given. Their use is routinely found in many dental specialties. Advantages of temporary RPD is that they are easy to fabricate, inexpensive, usually easy to repair, and can be made fairly quickly. They have significant disadvantages which limit their use. Because they typically do not have rests, they may subside into the soft tissue with subsequent loss of tooth soft tissue attachment. This is especially true in the mandible, since alveolar ridge assumes most of the support function. They may be easily broken and will not prevent tooth movement. Temporary RPD may be used as a treatment-type prosthesis. In cases of inflamed or abused tissue, they provide a vehicle to support tissue treatment material. Tissue treatment material is a low-viscosity material that may be applied to cushion the prosthesis, allowing the soft tissue to heal. It may be applied to tissues inflamed by candidiasis. Patients requiring restoration of vertical dimension may wear this type of partial at an increased arbitrary vertical dimension, to test their ability to tolerate the increase, as well as their compliance with the dentist's requests. It may be used in oral surgery as a stent, both to guide the surgeon in tissue removal, and to act as a subsequent bandage for the surgical site. Patients experiencing various types of occlusal disorders may be treated with a type of RPD designed to accommodate various occlusal therapies. The transitional type of temporary RPD is a prosthesis to which artificial teeth will be added periodically. The patient may be a candidate for a complete denture, but opts not to have the teeth removed at once. This may be for reasons of health, finance, or other psychological reasons. The interim partial may be thought of as a partial used, while the patient is awaiting or undergoing more definitive treatment. For instance, a patient who will be receiving a long-span fixed prosthesis may wear this prosthesis, while the ridge is recovering from surgery. They may be employed in young orthodontic patients, to facilitate tooth eruption or aesthetics, and may also be fabricated for patients, whose health, schedule, or aesthetic emergency requires a replacement. The definitive temporary partial is constructed when circumstances preclude a better solution. These are designed for longer-term usage. They may be designed and used with tooth preparations similar to a cast partial, but are generally all acrylic. Although the use of such restorations should be limited, occasionally they can be fabricated for patients with the understanding that they are basically a temporary until a better long-term solution can be found. In terms of design, they are similar to the cast partial, with similar requirements for interdental space, rest preparation, guiding planes and retention. A ball clasp is illustrated to provide vertical support. This may require tooth modification to use. 19-gauge wrought wire may be used as a retentive clasp, and in addition, parts from previous dentures may be used. A ball clasp is illustrated as an embrasure clasp, and an older framework component is illustrated. Other indications for this type of partial include patients undergoing extensive prosthodontic treatment, when restoring vertical dimension, and when stability is required. Retention may be provided by wrought wire circumferential clasps and ball clasps that engage embrasure spaces. Maximum tissue coverage of the base is desirable for stability, and to reduce subsidence into the tissue. The illustration shows how the wrought wire clasps are bent to conform to the tooth, as well as a ball clasp. These clasps may cause tissue trauma, such as wedging of teeth, occlusal interference, fluid impaction, and trauma to the periodontium. The illustration demonstrates one technique for the fabrication of the RPD as follows. Obtain a diagnostic cast, tooth shade, and bite registration if needed. Survey the diagnostic cast. Block out interferences to insertion with blue wax. Duplicate this cast. Alternatively, one can use whetstone as a blockout material. Next, place the retentive elements and teeth with wax. Index the position of the teeth with stone. Remove the teeth and eliminate the wax. Replace retainers and teeth using the stone index. Use auto-curing resin to unite the various components. Finish and polish the partial. As an alternative, the partial can be invested and processed with heat-cured resin. Most partials are easy to adjust in the mouth. Unless otherwise indicated, the occlusal position should be the patient's MIP. Care must be taken to carefully adjust lateral deflective contacts, and pressure indicator paste should be used to eliminate areas of tissue interference. Borders should not unduly impinge on movable tissue. The process of having a flangeless tooth is illustrated. This can provide a better-looking tooth replacement. Problems. These partials can be difficult to insert if blockout was inadequate and undercuts are present. Again, because they do not have positive vertical support in the form of rests, they may cause or contribute to fluid impaction, mobility, attachment loss, and periodontal trauma. Patients must be educated with respect to care and use of the partial and what to expect. They may be made of auto, light, or heat-cured acrylic, and may be fabricated with soft liner cushions. When inserting, use pressure indicator paste. Interferences are common in guide plane areas. Be careful not to force the RPD into place. Adjust the occlusion. Provide patients with instructions that are compatible with the purpose of the RPD. Usually, this would be to leave out at night. Use a soft brush for cleaning. Soaking in denture cleanser is good, and avoid dehydration. Inform the patient that a prolonged period of non-usage may prevent the RPD from going into place. Patients should be placed on a documentable recall schedule.